Welcome back to the Gillett Health podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. And today we're going to be talking about contraceptives, IUDs, patches, pills, all kinds of contraceptives, all kinds of bioidentical and synthetic hormones. So I guess the first question is, are contraceptives good or bad? What are some of the good things about contraception?
Yeah, so contraceptives are like any other medication. There's a lot of good, there's a lot of bad, and in general, there's just a lot of confusion. So contraceptives, especially oral contraceptives, are just looped into one huge bucket, and people are often in one of two camps. One camp is they emphasize the bad, so risk of venous thromboembolism, breast cancer risk of depression, risk of low bone mineral density or bone mass, and various others. And then some people just emphasize the good. The main one is it's a contraceptive, and having or not having the ability to conceive at a point in your life that you may want to or may not want to is one of the biggest benefits that anybody can derive. But obviously, sometimes they're not prescribed for contraception. So there's other benefits like control of estrogen dominance, androgenic symptoms as well. For example, hirsutism, hair growth, acne, et cetera, and then other gynecologic problems like heavy periods. So menorrhagia, dysmenorrhea, et cetera. But it's just like anything else. You need to weigh the good with the bad.
Yeah, and it's interesting to see this sort of discourse in the pro-contraception and anti-contraception camps, because they will definitely straw man each other's positions, where it's, you're treating women with contraceptives, you must want them to be depressed and to have heart attacks and to get breast cancer. And then you'll see people on the other side where it's like, well, you must want women to have unintended pregnancies and have the consequences of that. So really, it kind of speaks to the state of contraceptive information that's available to women today. So for example, if I go to what is perceived to be quite a reliable source of health information, let me just pull up a page on the Cleveland Clinic here, because I want to know about hormonal IUDs and what exactly they are. So according to Cleveland Clinic, Mirena is a hormonal IUD. The device releases a small amount of the hormone progestin into the uterus.
Yeah, progestin is not a hormone. So progestin is kind of a class of hormones, the synthetic progestogens. But this is very misleading, and this just adds to the misconception that all oral contraceptives are in the same bucket, or all contraceptive hormones are in the same bucket. So, whether it's an IUD or whether it's an injection or a patch or a vaginal ring, then they all just must be generic estrogen. And we actually do have more than one estrogen, like synthetic estrogen now, and generic progestogen. So just like we love like synthetic hormones of all types, we love talking about the risks and benefits of different progestogens and different estrogens. And your doctor should be, even if he or she does not like to talk about them, they should be very familiar with the pros and the cons. And really, they should be able to talk about the pros and cons of different ones when it applies to your situation and help you understand it in your own terms.
Yeah, so I think a fairly easy way to break it down for people, and maybe I'll lead into this with a question that I had on a nursing exam many years ago during my associate's degree. The question was, which hormone is responsible for the symptoms of PCOS? And the answer was androgen. So this is very similar to what we're seeing here on the Cleveland Clinic website, where a hormone is being named a hormone class. So to kind of build a family tree, if you will, you have the androgens, which are things like testosterone, which is bioidentical, and then synthetic androgens like oxandrolone or nandrolone, which some of the contraceptives are derived from.
Yep.
You have the estrogens, E1, 2, 3, and 4 now, which are technically bioidentical. Yep. 4 is an interesting one, but you have estrone, estradiol, estriol, and then estetrone.
Estrol.
Yep. Estetrol, that's right.
Estetrol.
E4 is estetrol.
Yep.
So you have 4 somewhat bioidentical estrogens, and then you have things like ethinyl estradiol or conjugated equine estrogen, which are synthetic estrogens.
Yep.
And then you have progestins, which is a class of medications that bind to the progesterone receptor. You have levonorgestrel, drospirenone, number of other progestins as well, medroxyprogesterone, all kinds of these. So when we talk about progestins or androgens or estrogens, it can be very confusing because someone could be referring to any hormone in any of those classes, and they may just call it, oh, well, did you get your estrogen checked? Or are you taking estrogen? Or are you taking androgens? So there's a lot of nuance to it. But I think that framework will be helpful for people to at least keep up when we're talking about the different classes of hormones that are out there.
Yeah, and I'll also have a post on my Instagram with the differences between different progestogens. Progestogens specifically are in different generations or classes. So you have your first, second, third, fourth, and depending on what generation they're on, it's usually based on what molecule. You mentioned nandrolone, which is 19-nortestosterone, and you have many different progestogens based on that. You also have one now based on spironolactone, and then you have ones based off of progesterone as well. So you can take two different progestins, which are apparently the same thing, according to Cleveland Clinic, and other than the fact that they are an agonist at the progesterone receptor, which, by the way, we don't know a lot if it's progesterone receptor A or B, they can have other opposite pharmacologic effects, not only on the androgen receptor, but on the estrogen receptor, the glucocorticoid receptor, the mineralocorticoid receptor, and then have different effects on coagulatory risks as well.
So it sounds like something that's an agonist at the progesterone receptor could actually even be an antagonist at the androgen receptor. And it sounds like that could affect mental health. And looking at, again, the sort of state of information in contraceptive literature, we have this kind of gem that we came across of the risks of severe depression, anxiety, and suicidal ideation with hormonal conception. And this is a company report put forth by Bayer. So we'll just go ahead and scroll down through this and see if we can pick out some gems from this report.
3.21. It's good data from 3.21.
So there's the heading and a couple dozen pages. And, well, I guess there's nothing concerning about mental health that was uncovered by Bayer in their company report.
It's all redacted. It looks like a government document.
It really does. But we're just using this as an example to sort of speak to what is, I guess, not openly discussed or not even openly posted online about different contraceptives and their effects on mental health. But as mental health comes more to the forefront, you do have these, sort of health sources, or not health sources necessarily, but influencers putting out information about contraception and mental health sequelae. So we might as well dive into it. Sometimes these people are doing a bit of fear mongering because clearly not everyone who takes a contraceptive develops depression, but there are reasons why some contraceptives may be better than others or worse than others for someone who, let's say, has a predisposition, maybe family history or something genetically that predisposes them towards depression.
Reading a study like this, you always look at how the study is designed. So, they have two different groups of people, no use of hormonal contraception, and then all hormonal contraception, and then groups, for example, specifically the levonorgestrel group with high estrogen, medium estrogen, no estrogen, and an IUD. One of our first questions was, well, why is the first diagnosis of depression so much lower than the first use of antidepressant? And reading the fine print, it looked like they define that as diagnosis of depression at admission, like psychiatric admission. So quite severe.
Yeah, it's some sort of, psychiatric facility. So my question was, wouldn't the diagnosis of depression typically precede the prescribing of an antidepressant? So we dug in a little bit deeper and found out that that's where that sort of disparity in the numbers were. But looking globally, you have someone who has not used contraceptives and their risk ratio is 1. And if you look at everyone who takes any form of a contraceptive and their risk for first use of an antidepressant, their risk ratio is 1.2. So that means they're at about a 20% increased risk of using an antidepressant.
The 95% confidence interval for that was 1.22 to 1.25. So that's a pretty narrow range. That's relatively good assurance that yes, it's between that value. So that's statistically significant, and we certainly think it's clinically significant as well.
Yeah, I think this does play out in the real world because there's a really significant number of person years here. Looking at, I think it's north of 3 million person years in this study. And one of the interesting things to me was looking at when you have a progestin combined with an estrogen versus when you have just a progestin. The progestin-only contraceptives seem to have a pretty profound increased risk, in my mind, for causing depression. They have about a 30% increased risk versus something like let's say 20% with just global contraceptives. And then if you go an even more granular at another level, if you're using a progestin-only contraceptive that also antagonizes the androgen receptor, those have an even more significant increased risk for depression, meaning the first use of antidepressants in this column. So that one is up to about a risk ratio of 1.4. So I think that's really interesting. And it almost seems like having androgen signaling and estrogen signaling might be important for people's mental health.
Yeah. And there's, of course, many causatory reasons for this. Some of the main ones is estrogen is involved in the conversion of tryptophan to serotonin and serotonergic signaling. So if you're not estrogen dominant, then it's probably a particularly poor choice. But if you are estrogen dominant, maybe it still is a decent choice. And then you already mentioned the predisposition towards anxiety and depression. If there's an individual who is already somewhat dysregulated, then it might not be a great choice. The anti-androgen contraceptives, you think, androgens are close cousins of dopamine. Androgens can help effort feel good. Dopamine can kind of be the motivation hormone as well. They did not delineate between why the first use of antidepressants was. So it could have been depression and it could have been anxiety. Serotonin is very important in anxiety disorders, and SSRIs are actually first line for anxiety disorders. So it could have been both of these conditions.
Yeah, that's another really important detail. What about the levonorgestrel IUDs? This is really interesting that this is associated with an increased risk of depression. If I was looking at this and it was only that, say a singular study that said levonorgestrel IUD associated with depression, well, then I could think, well, maybe it's just that, some characteristic about this group that is seeking out contraception and willing to have this somewhat invasive procedure to place a contraceptive device. Maybe they're more predisposed to depression. Maybe they don't feel that mentally they're in a good place to conceive at this time. But this is in the context of being weighted to all other antidepressant or other conception methods. Yeah. And they still had a increased risk of being prescribed an antidepressant. But I see a lot of messaging out there that says that IUDs, all of which use the hormone progestin, actually they use the hormone levonorgestrel at this time, the 4 that are out there, that they do not go systemic. I see people talking about this, that they only work in the uterus. Then I see people that are being a little bit more responsible in their messaging. They say that they work mostly in the uterus, which I think is more accurate. So what are some of those changes that we see outside of the uterus with levonorgestrel, besides the risk for use of antidepressants here?
Certainly higher copper levels, even though it is not a copper-containing IUD. Paragard, of course, increases copper levels as well. And then you see a lot of changes in the ovary. Probably partly because the ovary is pretty close to the uterus, but it will change, and it kind of depends on the scenario, but about 20% of people, at least that's the number last I remember, do not ovulate while they have a levonorgestrel. And that also might change as the hormone level wears out toward the end of the IUD, but about 20% of people do not ovulate. In addition to that, there is small amounts that circulate systemically. And those small amounts very likely do bind to the pituitary and the hypothalamus and are potentially neurologically active. So there's quite a few effects.
Yeah, and one of the things with levonorgestrel in particular and synthetic progestins really is that they don't always play nicely with your endogenous progesterone receptors. So when you look at women who have had a IUD in place versus women who never used hormonal contraception, there are differences that are visible on contrast MRIs in the breast tissue. So there's probably a non-zero increase in risk of breast cancer, even with a progestin-based IUD. I would speculate. I don't have that data to pull from, but I would speculate based on some of this data that is available out there.
Yep. Anytime you talk about changes in the breast, and actually in multiple other systems of the body as well, then thinking about the push and the pull, or the tug of war between androgens and estrogens, is important. In the liver, this is very important with SHBG as well. But in the breast tissue, having adequate androgenic signaling can be important to kind of like impair the growth, whether it is, a normal breast tissue cell, like glandular breast tissue, or whether it is a neoplastic or pre-neoplastic cell.
Yeah, well, estradiol and estrogens don't necessarily cause cancer by themselves. If you have a cancer that is responsive to estrogens, it will certainly grow much more quickly than it would otherwise. And there's actually quite a bit of data on this when you're looking at the risk of breast cancer. So if I have let's say, a case study, a patient comes in and I know that they're at a high risk of breast cancer. Maybe they have a family history, or they have a BMI greater than 30. We know that's about a 20 to 30% relative risk increase for breast cancer. And then I'm looking at which, oral contraceptive makes the most sense for them. Well, certainly, according to this data, levonorgestrel only would be a poor choice because that has a 1.93 risk ratio for breast cancer. And not exactly a super tight confidence interval, but it's not way out there.
Yeah, and this is probably part of the reason why this isn't prescribed in the United States anymore. So there's been a lot of changes, but, and you would probably think that just between the depression discussion and the breast cancer risk discussion, that levonorgestrel is a poor component of any contraceptive choice, but this is actually not the case whatsoever. But it is good to assess that individual case and say, yes, you're not a good candidate for levonorgestrel, but perhaps a better candidate for a patch.
Yeah, it was interesting to see this, and the confidence interval is extremely wide here for the patch, but looking at the fact that there seems to be a potential for decreased risk of breast cancer if someone is using a patch. Another confounder there is that the patch is typically not going to work quite as well for someone who has a BMI over 30. So then maybe you're like, okay, maybe we don't want to do the patch. They can use the vaginal ring, which also seems to be just about neutral, potentially for an increased risk of breast cancer. And if you want to look at, they want to take a pill, then drospirenone is pretty close to neutral as well, with a 1.05 relative risk ratio. So there are options out there, and just because something has the lowest risk ratio on paper doesn't mean that it applies to that individual patient scenario.
It does seem like also on paper that if you put in, perhaps find, you're already taking a synthetic estrogen and a synthetic progestogen. What if you put in a synthetic androgen? That would probably decrease your risk of breast cancer.
Yeah, it's an interesting sort of postulation and thought experiment. I know you and I were on a podcast probably close to a year ago at this point, and we're talking about contraceptives and the free androgen index and all these effects, and kind of wondering aloud as to why there wasn't some sort of a synthetic androgen that was added into a contraceptive at some point. And I think it's partially because of the sort of reputation or stigma that surrounds androgens. It's like, well, that's a male hormone. Why would you give that to females? Which we've both spoken about many times, that there's actually, for most women, a higher circulating level of testosterone than there is estradiol. But I think we landed on something like 0.5 milligram to 1 milligram of oxandrolone as being a pretty solid choice. Because when you look at some of the studies with women in Turner syndrome, it doesn't appear to have a profound increase in insulin resistance. It seems to be neutral. Now, if you put these women on a euglycemic insulin clamp, maybe you do see that oxandrolone actually does cause a bit of insulin resistance, but maybe not. But certainly bioidentical testosterone seems to in a dose-dependent fashion, as well as some other androgens. So I think that's what we landed on. And sort of speaking to the tug of war, there's an opposing effect in the liver of androgens and estrogens on sex hormone binding globulin, and there's some pretty interesting numbers there when you look at how much something is able to raise that sex hormone binding globulin.
Yeah, you would think that the stronger the estrogen or the higher the estrogen dose is, the more SHBG is increased, because when it binds that estradiol alpha, that directly increases synthesis and release of SHBG. But progestins can have a profound effect on this as well. For example, drospirenone without any estrogen raises SHBG precipitously. So finding the nuance of that, not only in the liver, but in the breast tissue, is important. We love going through clinical literature, and regardless of it could be a synthetic estrogen, synthetic progestin. We love SERMs, selective estrogen receptor modifiers, SARMs, selective androgen receptor modifiers. We kind of lament the fact that we've missed many decades of research, both males and females, on androgens potentially included as part of hormone replacement therapy or potentially as part of contraceptives, largely just because there was a whole bunch of research and there was none. So I think that's really a public health problem that needs to be talked about and addressed more as time goes on.
Yeah, it's really, like I said, just this sort of reputation that testosterone and androgens have, where people don't want to touch it, a lot of times don't want to talk about it, and as a result, there's kind of a lack of knowledge in that area. So there's not a lot of attention that gets paid to it. So looking at the different forms, the different routes that estradiol can be administered, and I think we had a brief podcast on contraceptives in the past, oral contraceptives specifically.
Yep.
And I had thought at the time and kind of wondered aloud that, maybe if someone's taking oral estrogen, like ethinyl estradiol in their contraceptive, if they switch over to transdermal, like a patch, that they're not going to have that same increase in sex hormone binding globulin. And doing our literature review, our non-systematic review, if you will, for this podcast, I found out that's not the case, that there's actually similar increases in SHBG, similar decreases in insulin sensitivity whenever contraceptions with ethinyl estradiol are used. So, for example, contraceptive using oral ethinyl estradiol, sex hormone binding globulin goes up by a little over 200 points, pretty significant. About the same for transdermal, like a patch-based contraception, goes up from 63 to 264 approximately, so about another 200-point increase. Slightly smaller increase when you're looking at the NuvaRing vaginal contraceptive preparation, goes up from 61 to about 220, but still a really substantial increase. So there's something about that duration of effect of the hormone and always having that circulating, not just the first pass effect that is driving the sex hormone binding globulin and driving some insulin resistance. And we kind of speculated about the differences in lean body mass composition. So there seems to be a neutral or negative effect with oral contraceptives. I've heard some people postulate that maybe if you're taking a ton of estradiol, that it might be a little bit anabolic, but I haven't seen the data to support that. But maybe if you're looking at a transdermal delivery system, then that's going to be slightly better, because you can think of it as kind of like a testosterone pill versus a steady state of testosterone.
Yep.
And that steady state, and we know that women's estradiol is part of what drives their response to exercise, which is about proportional with men, according to their body size, based on some of the information that Dr. Andy Galpin has put out.
Yeah, I think this is a really interesting postulation. There could be a few other reasons why there is not as much difference between oral contraceptives, transdermal, and vaginal. And again, one way that I think about it is the serum half-life of the contraceptive or of the estrogen is not necessarily related to how much time it spends in the liver, because the first pass metabolism is just the first pass. After it's metabolized and whatever's absorbed is absorbed and bioavailable, and whatever's not is not, then that first pass skew towards oral contraceptives binding the estrogen receptor in the liver more is lost. So after that, and also ethinyl estradiol is just a very strong estrogen. After that first pass effect, things do seem to even out significantly.
Yeah, I think so. And it was really interesting to see just how close all three forms were in terms of raising the sex hormone binding globulin. And as you mentioned, androgens and estrogens, they sort of have this tug of war, whether it relates to proliferation of breast tissue, sex hormone binding globulin production in the liver.
Mm-hmm.
That's some of the times that it's actually appropriate to use the term hormone balance, which gets a bad rep sometimes because it seems like everyone is now a hormone expert, but very few are true hormone experts. So there are circumstances where it's appropriate to talk about balancing hormones, and there really is a balance between progestins, estrogens, and androgens.
Mm.
So talking about contraception a bit, if we circle back and kind of look at the opposite side of the spectrum, so conception. There's a lot of questions about fertility out there. What is a woman's window of fertility? I put out some information here recently looking at PCOS and the fact that they actually have, on average, a slightly extended window of fertility. So just because someone has some downsides from a condition that they have, it doesn't mean that there necessarily aren't upsides to that. But one of the things that women can do is check a AMH, anti-Müllerian hormone. And we'll have this up on our website where people can purchase this, go to LabCorp and get the blood draw and kind of plot themselves on their reproductive timeline and see where they're at. Now, do we know if this is going to be relevant in 5 or 10 years? Hopefully by then there's a way to extend the reproductive timeline that we can slow ovarian aging as the ovaries seem to age faster than other organs of the body. There's some other things that women could consider checking in addition to the AMH, but if you're looking at what's the most bang for your buck in terms of like putting yourself on that timeline, the AMH is probably the way to do so.
Nope. And as we've mentioned, things like taking oral contraceptives or being on hormone replacement can affect AMH, or even having an IUD can affect AMH. Anti-Müllerian hormone is very important in embryological development. The Müllerian duct is the duct that kind of is not inhibited in males, so it forms the male genitourinary tract, whereas in females, it forms female genitourinary organs. So as your AMH is dropping, many other things change. It's still important to track your cycles and consider using tools like LH, finding your LH spike, or even basal body temperature, maybe cervical mucus monitoring, but also considering workups like antral follicle counts like with your doctor, and things like day 3 ratios of FSH to LH and estradiol. So there's a lot of other things to consider other than just AMH, but providing these tests on our website is part of our goal to improve public health and public access to not only information on the podcast, but also things that can become clinically significant so that you do not have to wait until desiring fertility, so that you're being more preventive rather than reactive.
Yeah, just like we've spoken about, planning for menopause before you actually arrive at menopause, planning for conception before you're actually pregnant. That's important. And then also seeing where you are on the timeline of, your reproductive window is also equally as important. So I think it's important to sort of provide this information to people because there's not a lot of great sources out there. And we'll go through later on some ways to, potentially look at some of the downsides and decrease those risks for those downsides for women that are taking oral contraceptives. But if we're looking at, some of the, society-wide impacts that this has had, especially with moving towards either progestin only or lower doses of ethinyl estradiol now, we know that even combined oral contraceptives that have estrogens in them are going to, in adolescence, cause them to accrue a bit less bone mineral density over time. So the data is really interesting, and they look at women who are taking an oral contraceptive versus women who are not during adolescence. And the ones who are taking oral contraceptives, it's not that they lose bone density, but they kind of have this opportunity cost where they're not accruing something like a 7 to 8% increase in bone mineral density that would normally be happening during that time. So how far does that set someone back in the grand scheme of things? It may or may not be incredibly significant. And there are certainly ways that you can modify that with, resistance training, load-bearing exercise, being metabolically healthy. There's lots of different things you can do there to push back against that. But this is actually because, you have a dose-dependent decrease in IGF-1 and increase in IGF-1 binding protein 3 as the estradiol dose increases. So kind of counterintuitively, the lower dose of estradiol or ethinyl estradiol will actually affect IGF-1 less. And it's kind of hard to wrap your head around when you're thinking about this, but less estradiol may actually be better for more bone formation in the synthetic form.
Yeah, it's certainly interesting. It's also interesting looking at the ratio between IGF-1 and IGF-BP3. So IGF-1, think of it as, in general, the addition of your insulin and your growth hormone. Growth hormone release also causes IGF-BP3 synthesis and release. So IGF-BP3, that's like SHBG, but for your IGF-1. And IGF-1 is going to have a much longer half-life while bound to IGF-BP3, just like testosterone has a much longer half-life. So if you can, having during a growth phase, a higher free IGF-1 will come when your IGF-1 to IGF-BP3 ratio is relatively high, or both of them are high.
Yeah, I think that's a good explanation. And we can kind of put IGF-1 in this sort of growth factors family, just like we put progestins like levonorgestrel in the progestin family. IGF-1, insulin, growth hormone, all those sorts of things are considered growth factors, just to kind of keep this, categorized for people as they're trying to learn about and keep this information organized. And when we look at androgens, I think it's really interesting that the ovary can actually be a source of androgens still in postmenopausal women. If you would have asked me that question, 5 years ago, I probably would have been like, no, the ovary doesn't do anything after menopause. But apparently that's not the case.
Yeah, there is a wide variation among females with not only DHEA production. For example, NCCAH would be on one side of having a ton of DHEA sulfate, adrenal hypoplasia, like adrenal fatigue, whatever you want to call it. They'd be on the side of having not a lot, adrenopause, another term. Whereas testosterone can also vary quite a bit. So the theca cell can make a lot. Hyperthecosis, which a lot of female Olympic athletes have, would be on one end of the spectrum with a ton of testosterone production from theca cells in the ovary. Even after menopause, in some cases, the higher LH might help with that. Almost like a factory that is shutting down, but there's still a lot of testosterone on the assembly line, and there's a whole lot of signal to produce. So every once in a while, a whole bunch will be released. And then the adrenals also have a pretty high variation in the production of testosterone. Again, Dr. Fernand Labrie showed that the DHEA converts to estradiol. So after menopause, you're either getting your estradiol aromatized from testosterone directly or indirectly or intracellularly even from DHEA.
Yeah, it's really interesting. I like the factory analogy because you kind of see this bimodal distribution of testosterone levels in women. So, a young woman who's between the ages of 20 and 30, maybe she's at her peak testosterone production. And then that sort of trickles down almost like andropause would for a male until she reaches about, her 40s and then, hits menopause at, on average, age 51. And at that point, you have luteinizing hormone levels that go sky high. So your analogy, a lot of signal for production and a lot of ability to do so because those theca cells are not, burned out, so to speak. So you kind of have this initial peak and a trickle down, and then another peak later in life in the 50s where testosterone levels may be, essentially normal. And at the same time, you have your adrenals kicking in sort of as the backup factory, where you have DHEA being produced that then fills some of the functions that the hormones that were produced by the ovaries would. And people have different levels of, let's say, adrenal backup. And some people have very robust production of adrenal hormones. And, certainly adrenal hyperplasia can be misdiagnosed as PCOS if someone isn't doing a proper diagnosis of exclusion. I don't think we can go without mentioning PCOS in a women's health podcast. I think that's very important.
Yeah, and I know we've talked about PCOS a lot, but there are certainly going to be cases of people who have, maybe your naturopath or your biohacker has cured your PCOS, and really it's just because you kind of grew out of it, and then in the next decade of life, it might come back. Kind of reminds me of asthma.
Yeah, it's interesting to see some of that recurrence, later in life. And really the answer there when I've asked some allergists about this is they say immune dysregulation. And we don't know really what that means, but the immune system behaves differently when you're older versus whenever you're younger. We do have a more clear view of how this bimodal distribution of androgen production happens. And it's important to remember that even if a woman is not producing significant amounts of androgens postmenopausally, let's say that she's a candidate and would benefit from testosterone replacement, 10% of the population is estimated to have PCOS. The true incidence, prevalence, maybe a little bit higher than that.
Yeah.
So those women will be more sensitive to androgens on average. So, it's always good advice to, start low, because you don't want to cause side effects. You don't want to give someone a bad taste for a medication that could improve their quality of life. It's like if I, have someone that comes in and they have high blood pressure. Do I put them on the max dose of blood pressure medication? Nope, because they're going to feel pretty bad. And they're saying, well, I'm never taking blood pressure medication again. I felt like crap.
Yeah. And maybe their blood pressure is 190 over 130. You don't instantly bring them down to 110 over 70.
Why not?
Even if their blood pressure was 110 over 70 when they were 20.
Yeah, that's another great analogy. You don't necessarily want to recreate the state someone was in their 20s, even though that's the time period that people may be optimally healthy.
You may want to recreate the ratio, but not the absolute number, not the quantitative number. So the data certainly helps, and we're certainly advocates of getting labs early on in life, partly just to be proactive, but that's a good clinical pearl.
Yeah, I think that's interesting. Now, looking at, let's see what our last study is here. Some of the newer estrogens. So we talked earlier about E1, 2, 3, and 4, and this estetrone. Am I saying that correctly?
Estrol.
Estetrol.
Yep.
Estetrol. So E4 is estetrol. This is a newer estrogen that is technically bioidentical, and it seems to be, on paper, one of the more favorable estrogen components that could be incorporated into a HRT protocol, whether that's premenopausally or postmenopausally. As I believe, perhaps yourself coined the term premenopausal HRT as sort of a proxy for hormonal contraception.
Yep. Yeah, that's the way that I see contraceptives, is synthetic HRT, because that is exactly what they are, is synthetic HRT.
And what about these providers out there who, tons and tons of birth controls being prescribed, but then there's a really strong aversion to prescribing postmenopausal HRT for women. People are like, oh, don't mess with that stuff. You're going to get breast cancer and have a heart attack. But then oral contraceptives are prescribed to really anyone that requests them, and sometimes with significant contraindications.
Yeah, there's a couple of reasons for this. One could be selection bias. So the patient population is usually 50s and 60s for postmenopausal HRT, whereas for contraceptives, often 20 and 30s. So lower risks, at least at the time, of things like breast cancer and venous thromboembolism. But really, a lot of it is just lack of understanding and a not wanting to do shared decision making in someone who is more likely to benefit, but also more likely to have a detriment from a therapy. So if your doctor is willing to prescribe oral contraceptives, but not willing to have an HRT discussion, then understanding why that is, because oral contraceptives are far more complicated with far more different pharmacodynamic effects depending on which one is chosen than HRT. HRT is much easier than managing contraceptives.
Yeah, if you're looking at it and trying to do a really good job and really individualizing the contraceptive choice for the patient, it's going to be a much more time-consuming and complex discussion than a standard protocol for bioidentical hormone replacement for a woman after menopause. So, for example, in this spreadsheet we have here, you have to think about the androgen receptor, whether it's a antagonist or an agonist. You have to look at the pituitary effects, whether it actually suppresses pituitary function,
Yep.
whether it gives you adequate opposition to estradiol in the endometrium.
Mhm.
And also, there's even effects on like mineralocorticoid receptors that you have to think about. And there's a laundry list of synthetic progestins here. And I think the synthetic progestins have sort of gotten a bad rap, probably out of the Women's Health Initiative, where they just don't play nicely with your own progesterone receptors. But as we covered in some of the data here, some of the newer ones, as they've gotten more refined,
Yep.
some of those risks have not been completely eliminated, but drastically reduced for things like vascular events and breast cancer incidents after using these for a period of time.
Yeah, it's very important not to just refrain from prescribing an entire class, because one in the class does not have good outcome data. So there's a reason why a lot of progestins fall out of favor and fall in favor. But understanding the pharmacology of them and understanding like who is a good candidate and who is not a good candidate is something that each clinician that prescribes them should become adept at. I will go more in depth with this on an Instagram post, posting various charts of like receptor affinities, binding affinities. So like how strongly it binds the receptor, whether it activates or inactivates. So whether it's an agonist or antagonist, and then also the various effects of different classes on different receptors. For example, you mentioned, are they anti-gonadotropic? So do they decrease gonadotropins? One of the progestins that's often used in estrogen dominance or dysfunctional uterine bleeding does not. So some people might be a particularly good candidate for that, and some people might be a terrible candidate.
Yeah, there's a lot of factors to consider. And maybe we go ahead and touch on some of the newer developments in E4, which is basically, from what I understand, produced in the fetal liver. So if there was a hormonal fountain of youth, that would be the place it would come from. It'd be a good origin story anyway. But looking at the data on paper, it's kind of been back and forth. So on paper, initially, you had research that seemed to indicate it wouldn't have particularly strong hepatic effects. So things like sex hormone binding globulin, in theory, wouldn't be affected to a great extent. Now, in actuality, and as we have pulled up here, that doesn't seem to be the case when this is given to postmenopausal women. 15 milligrams, for example, you see about a 45-point increase in sex hormone binding globulin. Not the 200 that we see with the ethinyl estradiols,
Yep.
but it is still a significant effect. In this study, the authors seem to conclude that there was a sort of neutral effect on coagulation. So it wasn't a anticoagulant by any means, but it wasn't thought to be clinically significant in terms of increasing the risk for VTE. But it looks like it does skew slightly towards being procoagulatory, especially when you get into the higher doses, like the 15 milligrams versus 2.5 milligrams, which seems to have very little effect.
Yeah, and if you Google this, it still looks like it doesn't have significant hepatic effects, for example, on SHBG and platelets. And what that really should say is, compared to ethinyl estradiol, which is usually the synthetic estrogen, it does not have as significant of effect. So the syntax does matter in this case. That being said, I in particular was very excited for this, and so far, and the jury's not out, but so far the anecdotal cases have not been as promising as I thought they would be. But I think a lot of that's because a progestin was chosen. So drospirenone is what was chosen and is currently FDA approved in the United States. In Europe, there's, I believe, more options. But drospirenone was chosen, I think, because we know drospirenone 4 mg works on its own and is suppressive enough as a contraceptive. So because it's a new molecule, they chose something that they knew it would work well with, and they wouldn't have to worry about being suppressive enough. Because if you chose something that was less suppressive, then you'd likely either need to use a much higher dose of the progestin or a much higher dose of the estrogen.
Yeah, and I think you mentioned that there is also a drospirenone estradiol combination that not available in the US, but in some European countries, that this is able to be prescribed. And we know that oral estradiol still has some procoagulatory and inflammatory effects, but in a fairly younger population, so someone 20s, 30s who's taking a progestin-based contraceptive, adding some estradiol into that to perhaps help protect bone density. It'll be interesting to see some of the long-term data that comes from that compared to what's, a more common practice here, where you have someone who's getting drospirenone only, and then their estradiol levels are going to be significantly lower.
Not to name names, but it does seem like almost all of patients with endometriosis that come to me are on Yasmin, which is a drospirenone-based estrogen-containing oral contraceptive, usually taken for 3 months at a time. So not to get down like the endometriosis rabbit hole, at some point we'll have a podcast like specifically on estrogen-dominant symptoms or perhaps endometriosis or perhaps include PCOS again with that. We did have one last year on it. But yes, it is kind of like frustrating to see what people are trying to do and then see what actually comes to market.
Yeah, and things don't always pan out. If you look at preclinical literature, studies of mice and rats, I believe our colleague Alec McCarthy said it's about a 2% conversion rate.
Yeah, it's not
so
great.
You shoot 100 shots and you hit them twice out of 100 times in terms of getting a drug through the FDA approval process that's actually going to help people. And then sometimes there's post-marketing concerns and these things do get pulled off the market from time to time.
Yeah.
So not to end the episode on a defeatist note, let's inspire some hope in people. We really like putting out for the public health information, kind of putting ourselves in the viewer's seats and saying, well, if I'm someone who's taking an oral contraceptive, what are things that I can do to potentially mitigate some of these risks, or maybe what might be the right oral contraceptive for me in a given scenario? So maybe we'll do, let's say a case study. Let's say I'm a woman who has struggled with weight. I'm BMI is over 30, but I don't smoke. And I'm wanting to, take an oral contraceptive, but I'm worried that because I'm at increased risk for breast cancer, that oral contraceptives might not be for me, but I really don't like the idea of having an IUD.
Yeah. So great case study. One of the first things to look at is she desires a contraceptive benefit. Is she a BMI of 30 at 240 pounds? So it might not work as a contraceptive very well at all. So I suppose that's the first thing in and of itself. Thinking about breast cancer risk, thinking about what her predispositions are for anxiety and depression, perhaps ruling out something like a levonorgestrel. If she desires a contraceptive that works extremely well, then perhaps you do think about something like a Nexplanon, which is the implant. So each case is different. That's just one case. If she is going to take the shared decision-making process seriously, then she'd probably want labs before and after starting the contraceptive, just like you get labs before and after HRT. And think about things like, does she have enough boron? What's her testosterone production? What's her SHBG?
Yeah, I think those are some important characteristics that people can look at evaluating themselves, get a blood work panel, see what their baseline is, and then how those things are effective. Like, are your platelets going from 200 to 500 after starting an oral contraceptive? And, does that increase your risk for an event? Probably. Does it mean it's going to happen to everybody? There's people that have taken contraceptives for 2 decades that have not had blood clots. So, we're speaking in terms of population averages here, because plenty of people do very well. And they would still likely see increases in platelets, decreases in zinc. But I think that's a good case study for people to kind of put themselves in that person's shoes and say, okay, let's look at these things. So what are some of the, considerations or things that I can supplement with or do from a lifestyle standpoint if I want to, use, let's just say, an IUD or an oral contraceptive, and then, mitigate some of I don't want to be depressed, or, I don't want to have breast cancer. What can I do?
Yeah. Think about simple things like zinc. Often iron and copper are increased significantly. So getting some zinc to balance that out, and also potentially to decrease the uptake of iron. Think about vitamin B6. Think about boron. We mentioned that, depending on how much is in your soil, how many dates and raisins from turkey do you eat. So the lower your boron intake, the more it's going to help modulate SHBG. We mentioned adrenal function, whether it's adrenopause or whether it's adrenal hyperplasia. So depending on your DHEA might be a very reasonable addition. I think they've even studied the addition of DHEA to various HRT or birth control protocols. I think that there's also, I think Dr. Fernand Labrie actually considered putting DHEA in combination with a SERM for some conditions as well, a brand name, and did clinical trials on it, I believe in Canada. But that's certainly a consideration. We talked about Tongkat, its effects on the steroidogenesis cascade. That's potentially a good addition as well. And then we also like to talk about both blood thinning and also omega fatty acids in general. So there's a few good options for that.
Yeah, and one of the interesting things with the tryptophan dysregulation and vitamin B6 is it doesn't take very much. You don't have to be taking hundreds of milligrams. 5 to 10 milligrams seems to pretty well ameliorate that change that's seen in the tryptophan, and that can help to kind of shift the balance back towards serotonin functioning normally. That's not going to correct the way that the decrease in net androgens is affecting someone. Yep. So that's why boron and DHEA make a lot of sense. Looking at inflammation and the risk of blood clots, something that might make sense there for the right person would be baby aspirin, maybe taken daily or every other day, assuming this person isn't at a high risk for a head injury. So if this person is a downhill skier, or if this person is involved in some sort of martial art or law enforcement, probably best to stay away from that particular blood thinner. One of the more interesting things about EPA that's come out in general recently is its ability to, well, for one, thin the blood. Bleeding events are higher when someone's taking a high dose of EPA, but oral contraceptives are procoagulatory, so there could be a balancing effect there. And sort of a two birds, one stone, or two fish with one hook scenario here with EPA would be that EPA can attenuate the increase in C-reactive protein potentially. We know that women on oral contraceptives run higher levels of C-reactive protein. And if EPA is in fact able to correct that, then that may be another sort of vector that the depression and anxiety risk is aggravated by, because we know elevated C-reactive proteins are associated with depression and anxiety, and those with elevated CRP at baseline respond the best to EPA and higher doses, usually north of 2,000 milligrams.
Yeah, and perhaps that's one of the reasons why synthetic estrogens don't seem as cardioprotective, because you think bioidentical estrogen would be, is its effect on the acute phase reactants like CRP, one of the main inflammatory markers. We haven't given a lot of love to bioidentical progestogens, I suppose. Most people know we love talking about pregnenolone, progesterone, DHP, and THP, also known as allopregnanolone. And the allopregnanolone and basically just the DHP and THP do help with GABAergic tone. So they are an agonist at the GABA receptor to kind of help with that relaxation and prevention of paranoia or anxiety or hyperstimulation, and are good for sleep as well. So that's a reasonable thing to include, given that the synthetic progestogen is not going to be converting to those bioidentical progestogens.
Yeah, I think that's reasonable, because we talk about, that's one of the reasons that these progestins, maybe they don't play nicely with mental health, is because you're not getting that downstream GABA signaling. And the allopregnanolone is one that I think is getting more attention in the literature now. Pregnenolone you can take and increase your downstream allopregnanolone, and there's even a lymphatically absorbed allopregnanolone that's being developed now, presumably to treat things like depression and anxiety. And I believe the code name for that is LYT360. I may be totally wrong on that, but it's one of the things that I pinned up somewhere forever ago, because I was like, that's interesting.
It is interesting. There's an IV version that's FDA approved called Zulresso. Well, I think that's a pretty good summary. We've gone over a lot of different information. We've talked about synthetic androgens, synthetic estrogens, synthetic progestins, bioidenticals of all the above. In the future, we'll talk more about SERMs and SARMs for those who are asking more about those. Yes, there's a lot of combinations of medications and protocols that include SERMs, not SARMs at this point yet.
Zero human studies on SARMs for those that are interested.
Yeah, zero human studies. But there is certainly different combinations of SERMs along with other synthetic hormones. So we hope that this has been helpful. Please comment and ask all your questions. And we certainly plan to do more on this topic, including a Q&A episode.
Yeah, thank you so much for listening. Leave your questions and comments below. Let us know what your experiences have been like, good or bad, with synthetic or bioidentical hormones. And may God bless you with happiness and healthiness.
Take care.